guys here who might feel themselves outnumbered and maligned. I feel for you, and I'm a straight-up guy. I think that's pretty clear. I feel for you because a lot of this stuff that we do a lot of work for plaintiff lawyers, and I know the scene, I know the challenges. I take the position with a plaintiff client that if you're don't try to prove that something's the cause of X if at the end of the day you're going to fail. All the expense and evidence-based literature on fibromyalgia and trauma and all the rest of it. It's a somatoform disorder, by which we mean, in some mysterious way, the 25-year-old who's a stoic at home on welfare with 3 kids and is just barely compensated in life with all the stresses. You nudge her in a rear ender and she gets pain that persists. Is that any different from nudging an 80-year-old woman with osteoporosis on the crosswalk? I don't think so. I think somatoform disorders get short shrift. Because a lot of these people, not a lot, virtually all of them, they're not malingering. They have physical pain. They have symptoms that have no plausible explanation. But they were well before the accident. The accident happened, and then they had this continuous problem. And no one's suggesting they're malingering, and they didn't have it before. But so often they have this terrible psychosocial mess in their lives, in which they're just barely compensated, and this extra thing is enough to just push them over the edge. In BC that's handled a lot differently. There's more recognition of that as being related than there is in Alberta. But cutting across that, you see a continuum here. On this side, pathologic disease often has objective findings, and malingering obviously doesn't. But these guys don't have any abnormal findings, but they're real, most of them, with confounding issues that are cutting right across the interpretation of what's going on. And then just another final little study that came out recently, University of Pennsylvania. We all know that, how can I best describe this about appreciation of pain? Hungry mice feel less pain. They're somehow, their mind's somewhere else because they're so bloody hungry that they're not feeling as much pain. It's been shown conclusively, and it resides in a very small area of the brain. But here's my point. As you're all sitting here listening to me, I hope, you are unaware of the fact that, saying this slowly, you are aware of pressure on your backside, right? Until I said that, you were not aware of it. Now you are, right? Your brain has this remarkable capacity of excluding certain information that it considers irrelevant. The brain is a remarkable filter, but also accentuator of stimuli. And in many ways, that's what we think is going on with somatoform disorders, that somehow the brain's thermostat is reset and starts focusing much more on normal stimuli than it would otherwise. The point I'm trying to make is that we all have that selective ability to ignore and exaggerate symptoms without malingering, of which fibromyalgia, of course, is the classic example. So here we go, my final summary. Early medical information radically changes outcomes. Assessment should provide medical clarity, not certainty. It should try and encourage a faster resolution, which might bypass the delays of the public health system. It should be based on active treatment, evidence-based intervention. The cost is less than the cost of passive case monitoring as opposed to case management. And the ultimate outcome is self-esteem, especially for an employee. and informal consultations with medical, with IME companies can sometimes help you navigate that labyrinth with comfort without necessarily triggering anything, just closing it right there as a triage point. Dr. William Osler is my final quote. This is a Canadian physician who was absolutely brilliant, McGill graduate. He became a founding co-founder of Johns Hopkins Hospital in the States. He subsequently became the Regius Professor of Medicine at Oxford, a man years ahead of his time. He died in 1919, 100 years ahead of his time, because what he said was, it's more important to know what sort of patient has a disease than what sort of disease a patient has. We all react differently. Medicine it's the art of assessing all of that, all of those inputs, knowing the person as opposed to the disease. And he was 100 years ahead of his time, and he was a Canadian physician that got all kinds of recognition. Well, that's the end of my talk. I've overshot the time a bit. I apologize for that. We didn't get into a case study, but I would like to encourage any and all questions. If I don't know the answer, I will get back to you. Please.
We have a little door prize here too. As we do any questions, maybe I could, we were going to give away a new car, but this was only, we didn't get around to it. I'm teasing a little bit, but it was something else. This was something in our stash. It's a digital portable battery for phones. I'll have, this is a duplicate series of numbers. I'll have Dr. Hodkinson pull a number. It has to be somebody present, and we'll do questions. And then I can assist, as he's answering questions, I can assist anybody who needs accreditation, okay?
Who's 62? Because you didn't get it. Yeah. All right. The real winner is 48. Person left early, perhaps, in which case I get the gift. Right? All right. This one is 58. I mean, we can carry on till midnight, you know, but 58, the victim. You deserve it. Okay, listen, please don't go. Ask questions now, or you can stay and ask questions later. It's all the same to me, but some people might benefit from the question.
So those of you that have to go, fine, but we're going to stay here as long as you want. So please go ahead with your questions.
Yes, sir. Have I what, sorry?
Have you heard of Nuga?
Nuga?
It's a certain type of chiro treatment.
Nuka?
A
No,
certain
that's
type
a new,
of
that's a
chiro
new one
treatment.
on me. No, I never heard of it.
Yeah, it's a new one that they just came out with. It's not that new, but they do a lot of x-rays, and then there's a strange way they have to test it.
What I will share with you, and before the plaintiff lawyers leave the room, very interesting recent work on fibromyalgia to be substantiated. There's an important paper out there which thinks that a lot of fibromyalgia may be due to hypothyroid. This is not coming from some flaky naturopathic source, but serious internal medicine in the States. To be confirmed, but it's a hot news story. Yes, ma'am.
In a normal whiplash injury, how do you tell the difference if it's an exacerbation or an aggravation? What is the sign of each one of them?
Well, for it to be a permanent worsening, you really need some kind of pathology that is crossing a joint. So a fractured spine, fracture across a knee joint, facet joints can be fractured. And by the way, that's another important thing. I'm not pandering to you. I'm just trying to be very honest here. Clinical medicine has relatively limited discrimination in terms of imaging detail, right? and there's a lot of detail in the spine, in particular the facet joints. MRIs are not good at identifying the detailed anatomy of the facet joints, which some people believe are the cause of a lot of neck pain after whiplash. So it gets back to my very original statement, proving the absence of something can be philosophically and technically very difficult. It may be that, unproven yet, but plausible, it may be that a significant part of whiplash, certainly the ones that progress beyond 6 weeks, may in fact have had some injury to their facet joints that is not seen on imaging because they're too small and the area's poorly defined. But the vast majority of whiplash 1 and 2, you're really talking about an exacerbation, a temporary worsening of the arthritis, because it's not coming from the bones, it's coming from the ligaments and muscles around it, which is like simplistically like a sprained ankle. It gets better spontaneously. If I could describe what is appropriate treatment for a typical WOD1, WOD2 whipper, I would say to all the insurance people in the room, you'll never do this because you're afraid of your competitors saying you're hard ass. The treatment for a WOD1, WOD2 is very simply described as that. It'll get better all by itself. Take an aspirin, see me in the morning. Get on with life, go to work. It'll get better. You don't need all this stuff that's going on out there in every shopping mall. It's unnecessary. And it also has the potential of prolonging the belief that I really am sick and medicalizing individuals, because the body will repair itself. It does it very efficiently. And all this stuff that I talked about in passive therapies, it's totally non-evidence based, and yet it goes on willy-nilly everywhere. And that's the reason for the big B sign right at the beginning.
Sorry, I know we passed over this, but so how does that tie to chronic pain when people are like,
How does it what, sorry?
tie to chronic pain, like I had a whiplash injury and now 5 years later, chronic pain?
Well, unless again, I get back to the sensitivity of imaging. It could be legitimate and missed. But more often than not, it's probably a somatoform disorder, which means there is no underlying pathology. You're not malingering. It is real pain that has no pathologic cause. In other words, it's psychologically driven. Does that mean that the accident wasn't the cause? That's for a judge to decide. It's all that one can say is there's no plausible connection. Somatoform disorders are all to do with what is euphemistically called within a room like this, and don't quote me, the shitty life syndrome. You know, there are a lot of people out there that have a shitty life, and it takes very little for them to totally decompensate, even with the most trivial of change in their life circumstance, just because they're a complex individual with their own problems and stresses. And if it's a difficult issue. I mean, I'm not pretending to have the answer here. It's very humbling in this business, recognizing that these people most of them are not malingering, and they're in pain. They've been probably medicalized. They've been seen too often, and people have laid hands on them, and they've been made to do all kinds of stupid things. Who can blame them? Who can blame them? Yeah.
So you talked a little bit about the pressures that physicians are under to diagnose and to prescribe
Yeah.
certain things. And I'm wondering, in certain areas, and I'm going to pick on the Okanagan, because there's a good example there, where you have certain physicians that have a tendency to diagnose a high proportionate number of individuals with TOS.
Thoracic outlet syndrome.
Yes.
Yeah.
And they're doing surgery on it.
Right.
At a high rate, like we're talking thousands of people in a year.
In BC especially.
Very,
Yeah.
very unusual surgery.
Yeah.
Do you have any recommendations for how to do you overcome that when you've got, you know, what would be considered an expert, based on the number of surgeries they performed, indicating that this patient needs, this, I would call it a very invasive surgery?
The simple answer of thoracic outlet syndrome is that it does exist. It's vastly overdiagnosed. The treatment for it is very invasive and should never be undertaken unless there's extremely good reason. And the reasons really boil down to one of two conditions. Either you've got an accessory rib, an additional rib, the first thoracic vertebra has a rib that's sticking out and is causing the vasculature and nerves in the armpit and the thoracic inlet to be rubbed against, figuratively. Or alternatively, you've had massive trauma, you know, with fibrosis and all kinds of stuff going on in there that's affecting the nerves and the vessels. In the absence of those two conditions, which almost never happens in the cases that we see, it's a total fraud. You know, the signs of it, you know, the disappearing pulse and all that, inter-observer consistency is very poor. Even on imaging, looking at the blood flow with various movements of the arm and shoulder, very difficult to diagnose, but it's just not plausible in the absence of an obvious anatomic abnormality or significant trauma to that region. And people are making a lot of money out of it.
Yeah, so how do you, like, it's getting harder and harder to find an expert to refute.
Yeah, I know.
The diagnosis.
I know.
So, especially in Canada.
Yeah.
And like, there seems to be a tendency where, I don't know, practitioners don't want to go up against
Yep.
another practitioner, and turning to the U.S. is almost cost prohibitive.
Yeah, and it also
and it's not necessarily going to get you the result
Well,
you're looking for.
the
It's
judges
just
think you're doctor shopping if you go to the
Yeah.
US. Yeah, yeah. Very difficult to find. I agree. It's challenging for an IME company to find experts that are willing to counter, because they all know each other, these guys, right? And if you're not experienced in the field, you're not an expert to criticize someone else, and you're not an expert in the field unless you've done the surgery, and you know it's kind of a
chicken and egg.
yeah. No, I feel for you. But the bottom line is it's almost never present. Any other questions? If anyone wants to stay behind and ask me about fungal infections of your big toe, I'd be happy to. All right. Pleasure.
Thank you very much, sir.
My pleasure.
Really
Did you enjoy it?
that. Yeah, very much. so.
Good, good.
Thank you very much.
Who are you with?
I'm an employee benefit consultant.